Welcome from Charlotte, North Carolina. Curvebeam is here for the AOFAS 2021 annual meeting, and wow, the atmosphere is charged. There have been a number of podium presentations, special sessions, a number of posters, all about weight-bearing CT. And the conversation really is, what is the impact that weight-bearing CT is having on the specialty today, and how is it going to revolutionize the way foot and ankle orthopedics is practiced over the next 5 to 10 years? We're going to bring you great talks from the exhibit hall floor, so let's hand it over to our speakers.
Well, thank you to Paragon and Curvebeam for making this opportunity available to talk about how we're using weight-bearing CT to create patient-specific tailor implants for the treatment of some very difficult problems, whether it's avascular necrosis of the talus, failed total ankle replacements, talus non-unions. This total talus spacer is really transforming patient care. Now, when you look at weight-bearing CT imaging, up until recently, this was not possible. We'd actually used simulated weight-bearing CT scans to try to get the idea of what weight-bearing would occur through the foot and ankle for patients. And so the simulation would either happen with foot plates on the bed for the patients, whether they were flat or angled, trying to simulate that patient's ability to put weight through their ankle. The weight-bearing CT was introduced in 2012, and it's a specialized system to allow for patients to stand naturally and in minutes get access to a weight-bearing CT that gives us the anatomic information we need, as well as the joint information we need to decide what kind of solutions patients may require, whether it's a patient-specific total talus spacer or something more like a flat foot deformity that needs to be reconstructed, or a bunion procedure or something like that. Using cone beam technology, think of this as kind of a optimized X-ray. You can get low tube currents to allow for really high definition type of imaging in the form of a CT. It is reimbursed at a CPT code 73700, which is a CT scan of the lower extremity without contrast. But the reason why this is important to think of it as an X-ray is that it actually makes it very accessible in the office. So if you look at cone beam CT, it's a wide X-ray beam, one rotation around the anatomy, so it's fast, it's easy, it's quick for the patient to just stand there and get this done, and it's really optimized for extremities. Whereas you look at traditional CT scans, it's a narrow beam X-ray. It needs multiple rotations to go around the extremity to get the information you need, and multiple body protocols. So you need the radiology tech to plug in the protocol for whatever extremity you're doing, and it can take time to get those CT scans compared to a weight-bearing CT. There's great customer support for these products. On average, an orthopedic clinic can realize about $7,500 in monthly net profits with just 2 scans that are done two scans that are done per day, and Curvebeam can help provide some custom ROIs for this. But the real thing for me is that patients can be seen and in the same visit without having to worry about pre-authorization and coming back 1 or 2 weeks later, and then making another visit to get the CT scan done somewhere else, and then making another visit to see me. Patients can get this done all at one visit, and it's the efficiency of taking care of patients that really is the most appealing thing. There's a large patient platform that's available. It captures from the proximal tibia to the distal calcaneus, allowing us to get information that we need on anatomy, on, again, alignment issues and things that we need to consider when we're looking at patient-specific total tali. The scans then can be submitted to Paragon 28 to be able to create that patient-specific total talus replacement. So, expedited patient imaging, that is critical and very important. And I think when we look at patient satisfaction, and patients are now able to rate us on their satisfaction of their experience with us, this really helps that at one patient visit, they get their initial evaluation, the CT scan, and then an idea of what they may need for their surgeries. These surgeries can then get scheduled sooner. Why? Because there's not that 2 to 3 week delay for getting the imaging done. And then an orthopedic office can realize some return on their investment and capture more revenue, which helps the offices to implement new technologies. So here's some here's a case. This is a lady I inherited from the Charlotte area, actually. She had a motor vehicle accident, had a talus fracture, and then came in to see me. She comes in with these kind of x-rays, and she comes in already with a CT scan that's done. This CT scan is not weight bearing. The problem is that once a patient has done a CT scan, most insurances will not pay for an additional CT scan to be done in the first 3 months. So we go off what we have, we create a patient-specific total talus replacement for her. She gets that done. She does well for about a year, but then comes back to see me and is having more pain. Now we can get that weight-bearing CT, time's elapsed, and you can see that she's already got some subtalar and ankle arthritis in this joint. And maybe that was pre-existing on that earlier CT and we didn't appreciate it because it wasn't a weight-bearing CT. Maybe it evolved over the course of the year. Hard to know that without knowing the weight-bearing CT preoperatively. But ideally, to have that weight-bearing CT scan done preoperatively would have helped us out. So this patient went on to get a patient-specific total talus with a subtalar fusion and a total ankle in order to address the arthritis above and below the talus and get the anatomic talus that they needed. But like I said, this technology can be used for other things. If you're a believer in the three-dimensional bunion, you can get x-rays. This doesn't tell you exactly what you need to do in the operating room to correct this patient's deformity. So we can actually get a weight-bearing 3D scan that's weight-bearing, understand the level of rotational deformity, and then create the three-dimensional bunion in the right position, a right rotation, so that you get the sesamoids corrected and aligned as you would like. A lot of the companies are talking about this rotational deformity with bunions. Not all of them have it, but a lot of them do. And the problem with just getting x-rays, you don't know how much of a rotational deformity they have. So some of the systems don't even need a CT scan. They just ask you in the operating room, you kind of dial in your correction, look at the fluoro and see if you can correct it. But again, you're trusting your eyeballs, you're trusting the resolution of the fluoro, which we know is not perfect. So if you can preoperatively with a weight-bearing CT know that, hey, this patient needs a 16.5 degree rotational correction. In addition, for patients who have supramalleolar deformities, the weight-bearing CT scan gives you a lot of information on how much deformity you need to correct. Again, with Paragon and PSI, you can then create cutting guides to create the cuts, create a cage, a medial plate, correct the deformity, and get these patients better alignment, which hopefully translates into longevity to their native ankle and allowing them to hopefully avoid a total ankle replacement.
That was a great talk by Dr. Selene Parekh. Now let's head over to the Exactech booth where Dr. Mark Easley from Duke Orthopedics will talk about how he integrates weight-bearing CT into the preoperative planning process for his total ankles.
So this is my opinion, but I do believe that in the next 3 to 5 years, we'll see weight-bearing CT scan, at least for those centers that can have those units installed, will become the standard of care in assessing preoperative deformity and really just for routine two-dimensional x-rays as well, but we'll be able to get all of that information, that 3D information for planning purposes, and that really will be the direction we'll go, because it just gives so much more information. That 3D understanding for whether it's for ankle arthritis, for ankle replacement, or even flat foot deformity, or if we're looking at bunion deformities, we really want to study the entire foot in 3 dimensions. And I just don't see any other route we will take except for that 3D weight-bearing CT scan will be the standard of care in imaging for foot and ankle problems. All right, good. So hi, I'm Mark Easley, and I'm here to talk to you about the Curve Beam and Exactech Vantage ankle PSI integration, and this is done with 3D systems as well. Curve Beam is the weight-bearing CT scanning system that we've been using. We at Duke currently have a PEDCAT, and that's limited to the mid, not even quite to the mid-tibial level, but there's also a lineup that goes up into the knee, concludes the entire knee, and then we also have a high-rise that goes all the way up to the hip. So as this technology progresses, I'm envisioning that we're going to study this even more carefully, as some institutions are doing, more carefully to look all the way up to the hip to get the proper alignment. The reasons to use a weight-bearing CT scan, one is to really look at the internal and external rotation of the talar component as it relates to the tibial component. So weight-bearing gives you a true understanding of what the ankle looks like in a weight-bearing position, which we really haven't studied very carefully up until this point. So here's an example of one of my cases where I would have a weight-bearing CT scan as opposed to, which is in the central image there, and then off to the side you can see a non-weight-bearing CT. Give me a much better understanding of what it looks like in weight-bearing and helps me understand how I want to do this correction in the planning. This has been looked at more carefully, and as you know, there's a lot of research in weight-bearing CT, and so my charge is to apply this to give best patient outcomes by studying weight-bearing CT as it relates to total ankle replacement. And there's always a concern, well, if you're doing a lot of weight-bearing CT, what's going to be the radiation exposure for the patients? And it's a very low radiation level when compared to traditional CT scan. I think that's really important, and I learned that. So even plain films can be obtained from the curved beam technology, and then 3D information can be extracted from that. Why would we use patient-specific instrumentation? There's quite a bit of research now already where that allows for great accuracy. It really allows us to reduce operative time, tourniquet time, and it can really reduce costs because of that as well. What I like is the idea of planning the surgery before I do the surgery. So getting an idea of what the rotation is, what the alignment's going to be, and I can really map out even the sizing of the components or where the components are going to sit within the bone. That's very important. And it gives it this can be done very reliably. It's been done in other joints and other disciplines. It's being applied more and more to total ankle replacement. And I think what we'll see is even improved outcomes from what we see now by having patient-specific instrumentation. What about the Vantage ankle system? I've been very proud, obviously I have a bias, but I'm very, very proud to work with this team. And the reason the PSI is even more advanced is that other systems currently have a cut guide that's then, the instrumentation allows you to create a cut guide position, but then that has to be removed and a cut guide placed in its place. And so the newer technology, including that with what Vantage has worked out with 3D systems, is to have a block that is planned, put on, pinned in place, and that is in itself the cut guide as well. So I think that's really important. And with the Vantage system, we've actually worked out a system where if you don't have that technology where the CT scan goes all the way to the knee, that we can work it where it can be just to the tibial level like I described, with the lower level of the PEDCAT system. And then as we become more advanced and becomes this technology, the weight-bearing CT becomes more of the standard of care, we'll then extrapolate that and be much more accurate as we move up the leg all the way to the hip. And we can prep everything from how the alignment's going to be, what the rotation is going to be, and also sizing, as I mentioned. And it doesn't matter, in our system we have a curved talar component, we have a flat top, all this can be done and planned carefully. And so what we'll do, again, like I mentioned, we cut through the guide. So this is an example of the tibial cut block on the right side there, or I guess when you're looking at it on the left side there. And then on the other one is the talar cut block. And we have a coupled system, so 3D Systems worked out a coupled system for us. So the tibial cut is made first, and then off the same pins referenced from the tibia, we'll then place the talar cut block as we're doing the talus up to the cut block, and then the talar cut is made. And again, like I mentioned, we can get data all the way to the knee if we have the weight-bearing CT scan, like a lineup, or then even get hip data. But right now, it can be done. That's not a requirement. So if you want to use weight-bearing CT scan for this planning, you can use the standard PEDCAT as well. So this is what the block looks like. So it's not a big, bulky metal block that the 3D Systems teams made for us. It's a block that you can see through. So you can see I have some pins in place. There's some hardware that's there that I can easily work around. I can plan that too. If there's hardware that's going to be in the way, I know exactly where the need would be to remove that to make it fit. But you can see, I can see right through the block, and I can see the cut surfaces there. If you want to follow, if you can see the mouse there, here's where my cut's going to be, and that's been planned out. So I love this because it's a great visual, and ideally, obviously, we want to get to the point where we don't need to do fluoroscopy. But at this point, I'm still a belt and suspenders type surgeon, but I've been amazed at the accuracy of this technology, and the weight-bearing CT helps me get it aligned to where I need it to be. And so here you can see where I can plan this. This is through 3D systems where I have the CT scan data, and then the engineers will work to show me exactly where the cuts will be. But this is not necessarily where I have to have it. So I will have an opportunity to meet with the 3D systems team, and we'll work through an opportunity to get it exactly where I want it to be, and then that's the plan I sign off on. We'll go over that in some more detail. So here it is again, the planned tibial cut, and then here is the tibial cut block going on the far image here, and then closer to me, that's off of those same pins in a coupled fashion. I'll have the tailor cut block, and it's amazing to me because what I would think would be congruent or orthogonal isn't always the case, and so it's something that I have to get used to seeing, but it may be off axis in what I visualize externally, but the cut's going to be perfectly anatomic the way that I planned it with the engineers. And then here I can prep this and even prep exactly where I want the tailor component to be. So I've sized it, and you can see here I'm putting after I've extracted the bone from the initial tailor cut, then I put the tailor block back on. I put 2 pins in like I would in the traditional technique. But in a traditional technique, I'm spending a lot of time trying to get the size right, get the position right of the trial for the talus. This is all done in preoperative planning. So block is on, proper position, pin, block comes off, and then I just drop my lollipop, as we call it, but it's the tailor sizing guide, and it's going to be in the anatomic position that I pre-planned. So it saves me a lot of time, because this is a step for me where I'll do multiple different positionings till I get it right. This will get the rotation right, the sagittal plane position, and that's the sizing as well. I do think the implant matters. There are a lot of great implants on the market. The Exact Tech team took 10 years to work this through, and I think we've really come up with something that makes a difference. So it's a curved tailor component. It's a true dome, so it takes advantage of all of the support from the underlying trabecular bone from the talus, or if I feel more compelled, there's also a flat top talus option available, but I'd like to preserve bone when I can. And then the tibial component, you see, will take care of most, well, will take advantage of most of the surface area, and then also the pegs and the cage, they are all vertically oriented, so early weight bearing is possible because of the configuration of this, what then would allow for, or promote, at least my feeling would be it would promote bone on growth, and hopefully some bone ingrowth, particularly with that cage. And so you can see here we've got the 2 different options available. There's a locking mechanism to lock that poly in exactly in the proper position. And then I'll just take you through a case. So here's a 53-year-old female. This was actually my first case I did. So I chose one that's relatively easy. You would even look at it and think, my God, Easley, what are you doing? Why would you operate on this? There's no arthritis here. Well, she had several surgeries before this, and I was able to plan this out, but you can see here it only took 19 days. So it's within a 3-week window, and they can even do this usually I'm the rate limiting step, they can do all this within 2 weeks. But to get back to why I even chose this for an ankle replacement, here's the planning being done with the 3D systems team, but you can see there's a large tailor defect, and as I said, she's had 2 operations before and was just not improving. So if you look very carefully, you can see where the components I'm starting to plan where they need to be positioned within the distal tibia, and that's obviously the part that's not deformed. But I've got to make some kind of plan what I'm going to do with the talus. But I think the hardest thing we do is trying to get the tibial component rotation right. And so with the CT planning, and especially weight-bearing CT, we can get exactly where we need to be and superimpose that on the talus. But here, look at the sizing I can get. I know exactly where this component's going to sit. I can size this and get the rotation right. And here's a rendition too, or the computer generation of where the pegs will be. So I know sometimes there's a concern where the peg will be encroaching on the cortices. Not going to be an issue here because I've got this all pre-planned. And then this here is an example of what you can do. And see, I love this technology. So it's not just looking in 2 dimensions, but I'm truly looking at it in 3 dimensions. And I'll know exactly where that component's going to sit. And it's all on me. The onus is on me to make sure that I put it exactly in the position I want it to be. And I've had cases before where I was upset with the 3D Systems team. I said, this is way in external rotation. This is wrong. So we went back, we talked through it, looked at it. It was all on me. I signed off on it. I had told them that I wanted that component in too much external rotation. So it's a very accurate system, but I do all the planning ahead of time. So there's the tibial component. And then I've got to plan this talus. It's a little more complex because of the cysts, and the resurfacing option not as good in this patient, so I opted for a flat top to remove all the unhealthy bone. And you can see the planning here. I can plan it exactly, the rotation. This is based on a weight-bearing CT, so I can also superimpose the tibia on top of this, but I can get exactly alignment. This is where the foot's going to be when the patient weight bears. That's very useful information to me preoperatively and then intraoperatively. So here you can see where I put the component exactly where I want to have it, and I've resected the bone as needed. And then this is what it looked like at the completion of the procedure, perfectly positioned. And I never used any external tibial alignment guide. It was all based on my preoperative planning. And the bone was resected. The unhealthy bone was resected. The ankle's well balanced, and it's perfectly positioned. I couldn't do it any better. And with this, I didn't have to do it at the time of surgery. I just had to confirm what I already preoperatively planned. Here's a second case, a second surgery that I did. You can see this is more advanced arthritis. I've got 3D imaging and renderings of what it's going to look like. And there I am. I'm going to start planning this and figure out exactly the alignment I want, and exactly where the component's going to sit, and exactly where the rotation needs to be according to what I think would be best position. You can see that here again, tibial component. I know where the medium malleolus is. I'm not going to let this externally rotate. I'm going to get the best possible coverage for this. You can see here I'm planning this out, and even here's the instrumentation there. On the weight-bearing CT, I'll know exactly where this sits. So to me, this really makes it so much easier because I'm planning it all in advance. And this is a good example of the weight-bearing CT where I've superimposed the tibial component on top of the talar component, and I can start looking at the options of rotation and making sure I get the rotation where I want it to be. And that's how it'll be planned, and I know that's where the patient's going to weight bear. So I think that's a huge advantage. This here is how the 3D Systems tibial cut block will come. So there's a model of the tibia so I can get a feel for where that needs to sit before I actually put it on the bone. The little extra work comes in and I have to clear more periosteum than I'm used to clearing, but that doesn't take too long, and then I can get that same feel that I just had on the model and position it where I need it to be. Here's the planning stage that comes with the system. So I'll put that up next to my fluoroscopic view. You can see exactly matches what I've planned, and so I'm confident the cut block's in the right position. Again, ideally I'd get to the point where I no longer need to look at the fluoroscopic image, but I'm still in the phase of checking this just to make sure. These darker areas are the pins that go in. This one that's at an angle is an oblique pin just to hold it even in a better position. So there are many fixation options for this. And then the same thing is true on the sagittal plane. So I have an angel wing type device to show me the resection level and the slope. But this is my plan, and here it is in surgery. It can't be more accurate than that. And all I had to do was put the cut block on, pin it, and it was in the right position. I didn't have to go through a lot of checking or changing things. You can see this serration. It's actually pretty clever, putting the saw blade that I use in as my reference point to get the slope. So here's a tibial cut block in place. I'm making the tibial cut. Here it is. We can see where I've made the tibial cut, and now I'm using the same tibial pins in order to do my talar block. So the talar block's dropped. I've still left the bone in. So in this particular technique, I have a coupled block for the talus and the tibia. So I leave the tibial pins in, tibial cut block comes off, and then I put the talar cut block on, what you see here, and then I pin that in place. And you can see here where I've got the angel wing, which I'm going to check. And then sure enough, here it is. It's exactly according to my plan. And all I had to do was pin it in place and then bring the talus up to the talus up to the talar cut block. And this was a little closer view, so I just double check that and make sure I have exactly what I'm anticipating. And then I love to do this. I love to put the plan up against it. As I mentioned before, through that tailor cut block, I can then drop the pins in that I normally do. Instead of me trying to figure out exactly where the sizing guide needs to go, I can put it exactly where it needs to be based on my preoperative plan. So you can see it here. This is in the surgery. Through the cut block, I've pinned this in it's in accordance with my plan. And then this is what it looks like at the completion of the procedure. And I can't ask for a better alignment, and I really didn't do anything more than just follow what the cut blocks told me to do. And I've already done all the surgery really before I ever entered the operating room with all the planning. So that really makes it a whole different, much easier for me, and I can do it with confidence. Here's a 66-year-old female. She's got more advanced arthritis. She also, as you can see, she has a large anterior osteophyte. And I wanted to show you this case. I just thought this was fascinating. I actually didn't catch this before the surgery. So weight bearing, you can see the talus is actually walking back. So we'll think about that as the talus backing up. So we got the talus is sitting slightly posterior, and you've got the anterior osteophytes. That's weight bearing. So to me, I thought this is going to be a real challenge because I don't have much of the talar surface to work with. Now in the operating room, the patient will be non-weight bearing on the table, so I would have a little bit more, but I planned this out. I didn't really pay attention to that tibial, if you look at the tibial osteophyte actually is in front of the talus. So we'll get to that in a minute. I did have full-length tibial x-rays that I can superimpose on my CT scan that's more distal since I have just using the PET CAT. But that'll give me another idea of looking at the longitudinal axis. So that's another way to get it if you don't have the full lineup or the high-rise PSI instrumentation. But this is what it looks like. There's a plan that comes to me. I've got the resection levels planned out. I've got the components in place, even telling me the sizing of what it would be. So I've got the rotation determined already. I know where the talus is going to sit. I know exactly where the cuts will be, and again, like I said, the sizing's already done for me. And so I'm going to plan this out, and this is the difference here, which I find interesting. If you watch here, you can see the tibial components just moving just a bit. I'll run that through one more time. But see, with the planning, I can decide where I want that tibial component to be. So I can make subtle adjustments in the planning phase and put in more varus, more valgus. And the two lines you see, one is using just the distal tibial axis. This is what I'm really keen on, which I cannot do in surgery very well without the preoperative planning. I think I do it pretty well, but I can definitely do it well when it comes to with the 3D system. So you can see here I can make the sizing, I get the sizing exactly right, and I can get the sizing I can do pretty well, but it's the rotation. So I can rotate this and put it exactly where I want it to be to get the best possible coverage. And you can see here, this is the rotation I'm talking about. So if you look at it carefully, I wanted to have a little more internal rotation, easy to do, and that's how the cut's going to be made. I don't have to make that determination in surgery. I've already made that determination. I think that's really important. And then if you look here as far as planning the talar sizing, you can look here too. I'm making little subtle adjustments here to the talus. Sorry, it's skipping through there a little bit quicker than I want. But if you watch one more time here, you can see where, if you look at that talar component there, I can make little adjustments. I can get the sizing exactly right. And then I can look at that in a 3D rendition too, which I think is a huge advantage. And then I'll put the tibial cut guide on. There's a heat map, so I know exactly what I need to dissect out as far as periosteum is concerned. And then I'm able to put the cut block exactly in that position. There are also some reference points that are given to me, so if there's a landmark, it's easy for me to look at in surgery to follow this plan exactly. And then I'm going to plan this tibial slope too, and you can see here where I can make little adjustments to it. And this is all done preoperatively, so I'm not doing this in the operating room. It's all done, and I can plan exactly where I want, and this is where the cut guide is going to sit. So once I've done all that, I've got a simulation of the tibial component. And what I love about this one case I wanted to show you was that tibial osteophyte is so far down anteriorly that I actually, in order to then make the talar cut, I had to cut through the tibia again. No problem. See, 3D systems had no problems with that at all. So you can see the talar guide positioning. And I just didn't pick up on it at all until I got to this stage. And in surgery, I said, my God, I'm actually going to cut through the tibia to make the talar cut. But again, to me, that seems complex to 3D systems. And even though it's a weight-bearing CT and we've got it all lined up well, this is really no problem at all. And then I've got the talar lollipop or sizing guide position I want. I've got all that planned out. And then here's the sagittal plane position. So if I want to make little subtle adjustments, I can easily move this talar component forward a bit. You can see that here, where I'm going to get exactly where I want. So look at it here. See, I'm just going to do these little adjustments. All this is done prior to the surgery. So I put exactly, get the best coverage. I don't have to do any more thinking when I get to the surgery, except for just a little confirming. So then I get an exact idea of what this is going to look like. And here I am positioning the tibial guide, sitting exactly according to plan, talar guide, but again with that osteophyte. And then when I drop this in, I did want to make this point. It is a flexible guide. It's not a metal guide, so we don't want to do a lot of tweaking with the saw blade. And what I'm trying to demonstrate here is it's just a system to trust. It works, it's accurate, and I don't need to do all those extra little adjustments, which I've often done in my traditional surgeries. And then the talar cut guide, I love this. I just wanted to show that one more time. It actually has it mapped out where there are two cuts. There's a tibial cut and a talar cut. So the model showed it to me that I'm going to have to cut through the tibia again in order to do the talar cut. So the talar cut block is going to sit there, but it's still going to cut through the tibia again in this coupled configuration. So you can see there, well, I've made the tibial cut, but my talar cut is actually going to cut through the tibial osteophyte one more time. So we're not going to remove those osteophytes at all. We're going to leave those because we really use all the bone there as landmarks, and then the osteophytes stay in place so I don't disrupt any of the anatomy there that I use for my preoperative planning. And so you'll see it here, it's sitting in position. And again, to me, I thought that was absolutely fascinating that I then made a cut through. The cut's actually going to go through the tibia again. And again, no sweat with this. It sits perfectly fine. And I end up making a perfect cut on the talus with this. And see, you can see that here. And then once I line that up, it's exactly through the tibia and through the talus. And that was just the point of that. So you can see here where I'm making the talar cut through the cut block. And then I'm going to be up here, and then I'll actually drop that through. And then I'll complete the cut down here. And again, no need to wiggle the saw blade, work the saw blade. It's simply, the goal is simply to follow the guides because I've done all that preoperative planning. This is just a double check on fluoro just to confirm one more time that I'm actually going into the talus, even though I have to go through the tibia first. So you get the idea. And then I've got to extract the resected bone, so you see that here, and my talar cut and my tibial cut. And this here is where the talar cut is. So you see it's just, the cuts are perfect. I didn't have to do much work at all. It was all just whipped through the cut blocks and that popped right out. Because the cuts are going to be exactly where I planned them, because the cut block directs me where I need to be. And then I got to be a little careful with the anterior tibia here, but you can see that I can make ideal cuts just by doing this all preoperatively planned. And then I will place this lollipop guide. So I've removed the talar cut block now, but I've removed it to remove the bone, extract the bone from my initial cuts. But what I then did was I dropped this in one more time. I put the talar cut block back on so I can drop 2 pins in the proper position there. And whereas before I had to put the lollipop and pin through it, now it's all been pre-planned, so I just have to put the talar cut block where it finds its perfect spot, and then I drop these pins in, and when I do that, then I just remove the other pins from the talus, slide this off, and then I have my 2 pins in position to drop my lollipop on, which I'll show you here. So you can see that just will come off. And now I'm right back. Now I'm back essentially to the traditional procedure, but I don't have to really think about this anymore because it's all planned. It positions the lollipop or the talar sizing guide exactly where I want it to be. And so you can see that in place, and then I'll confirm that just like I showed you before. I've got the plan here, and I've got the talar lollipop sitting exactly where I need it to be. And I never did really anything in the surgery to position that. It was already done for me with my preoperative planning. And then it becomes a standard Vantage total ankle replacement. You can see that here. And these are the final implants. And I'll conclude with one last thing that I mentioned earlier, and that is, if I have hardware there, it's really nice that I can work around that too. I can plan exactly where the component needs to be, and I can easily remove the hardware that needs to come out, but I'm not wasting time removing hardware that does not need to come out. So I think that's a huge advantage. And where are we going with this? Well, there are some studies there, but I think the key one to look at is really understanding the rotation of where a component needs to be sitting. And I think clinically and in surgery, some surgeons are good at it, but most are not that perfectly accurate. PSI, weight-bearing CT, getting accurate preoperative plan is the future of where we're going to do this much more accurately, and that I think is going to translate into better patient outcomes. And that's all I got, so thanks.